Hello, my name is Sam Klempner, and on behalf of Creative Educational Concepts, I'd like to welcome you to today's activity entitled Emerging Considerations for the Role of Biomarker-Driven Immunotherapy in Upper GI Cancers. This educational activity is supported by an independent educational grant from Bristol Myers Squibb. Today's program is brought to you by Creative Educational Concepts, which is an award-winning accredited provider for continuing education content. These are some of the activity types. This activity may include some discussion of some not yet approved therapies, so this is just a disclaimer that we will be discussing these. If you want to ask a question, which we do definitely encourage you to do, please look at the bottom of the screen for the ability to ask questions, and we will see those and we'll try to get to as many as we can as we go through the activity. There are also a couple built-in audience response questions throughout this deck, and it would be great to drive our discussion and hopefully make this as helpful as possible for all of you if you would answer so we understand where we can potentially focus some of the conversations. So who's here today? I'm Sam Klempner. I'm a director of the gastroesophageal program here at Mass General in Boston and an associate professor at Harvard Medical School. And I'm being joined today by a couple of outstanding colleagues, Dr. Samuel Citrin and Miss Leslie Swanson, and I will let them introduce themselves. Sam?
Thanks, Sam. Good to be here. I'm also Sam. I'm a GI medical oncologist at Memorial Sloan Kettering, and my research and clinical focus is also gastric and esophageal cancer.
And Leslie?
I'm Leslie Swanson. I'm a nurse practitioner in the GI oncology program at Fred Hutchinson Cancer Center in Seattle, Washington.
Perfect. Thanks for joining us. 3 hours different time zone, but we appreciate it's not at least 6 a.m. for you or something. All right, here is our objectives. So what we want to do is talk a little bit about utilizing biomarkers to select therapeutic approaches for patients with upper GI cancers, in this case, gastric and esophageal adenocarcinomas primarily. Talk about implementation of current guidelines and recent clinical evidence with the goal of really further individualizing the patient care through the use of biomarkers. And then really this is a disease where multidisciplinary care is central to get people and support them through the therapies. And so we'll be talking about the roles of multi-D clinics. So I'm going to talk a little bit about biomarkers, and then we're going to get through some of the data, and we're going to have some hopefully stimulating discussions throughout this. But really, biomarker testing occurs across the continuum of care for patients with stomach and esophageal cancers. There is still a lot of problems with this cancer. It's not like colon or breast cancer where we have screening. Most of our patients don't come into our clinics until they have symptoms, and usually that means they have at least locally advanced, if not metastatic disease. There is no screening test. Some people get endoscopies for other reasons, Barrett's, etc., but that is a rare subset of the population. We still are learning more about this cancer, and we don't have a lot of biomarkers that predict or match patients to therapy, unlike our lung colleagues or maybe even our colorectal colleagues, where they have multiple biomarkers and the majority of patients have a given biomarker. There's a lot of diagnostic delays because, when someone comes in with acid reflux or a sore throat or a little bit of anemia, cancer is not always the first thing on your mind. So there's often some delays in getting to the diagnosis here. Like all of our cancers, health disparities and access to care and access to high volume centers remains a problem. And then, no fault of anyone's else, but, biomarkers is not a word that people who are outside of medicine deal with a lot. So there's just a lot of unfamiliarity with what does that even mean. These are a complete list of biomarkers that are currently in consideration for stomach and esophageal cancer patients. On the left side, you probably are familiar with HER2, MSI, PD-L1, and Claudin 18.2, and we'll definitely spend a little more time talking about those. These other ones are a little less common or emerging. So FGFR2, we're waiting on some data in the near future, hopefully, to see if that one comes into routine practice. EGFR and MET are things that are often picked up by some of the sequencing assays that many providers offer. Same with TMB high. And then these NTRK fusions and RET gene fusions and BRAF, these are pan-cancer drug approvals. It's debatable whether and how often these exist in stomach and esophagus cancers. I've been doing this for almost 15 years, and I think I've not yet found a RET fusion in a gastric cancer, but doesn't mean I'm going to stop looking. Um, this is the current state of biomarker testing, and this is always a little bit humbling. So this is 60 oncologists out there practicing, were asked about testing. How often do you test? And 67%, so two-thirds of people HER2, almost two-thirds of people PD-L1. We see less than 50 and less than 25% uptake for some of these other biomarkers, including Claudin 18.2, which, since October is linked to an approved therapy. And then the providers were asked why. Why is this a problem? And the top challenges were limited tissue, whether they needed these results to just start therapy, and then some unfamiliarity with actually interpreting and applying the test results. Claudin takes a little bit of learning. HER2, sometimes you need IHC and FISH, and turnaround time and ordering processes. I think we all deal with, a multitude of clicks to get anything done in Epic or any other medical record system. But these are real world things. So I'm going to stop for a minute and just ask Sam and Leslie if, over the course of your careers, you've picked up any tricks to deal with some of these challenges. So maybe Leslie, I'll start with you. How are new patients handled, and how is biomarker testing sort of talked a little bit about in your clinic?
Yeah, so in our clinic, we do have a esogastric multi-D clinic. So new patients come through there, and as part of the nurse navigation process, if they haven't already had molecular testing done, then we do order an in-house panel that includes usually just the kind of initial four on that list that you showed. Haven't really expanded to the emerging ones yet. If as patients are progressing through therapy, then we may request an outside next generation sequencing to see if there are any special markers for that patient in particular. But I think the one thing that I've seen just in the years of practice is that it is still, you have to put in the order to request, whereas a reflexive test for someone who had an endoscopy, a biopsy that showed a esophageal adenocarcinoma, it'd be nice if that just triggered some process internally to already check for biomarkers such as HER2, PD-L1, Claudin 18.2 to kind of already start that process to get those results quicker.
Yeah, totally agree. We also have some mix of reflexive and ordering. Sam, what about you're at a big center? You guys have a high volume of this patient population. Are you, maybe a little different question, how often do people come to you with full biomarker testing results? And how often do you need to get some additional information, and how do you do that?
I will say, especially since the Claudin-targeted antibody zolbetuximab that we'll talk a little bit about later, but since that was approved, it is still relatively recent, and so a lot of the time we don't have that back yet. And to speak to one of the challenges that it sounds like some of the oncologists in the survey mentioned, not having enough tissue for these four IHC tests, let alone subsequent, next generation sequencing. One of the favorable facts or one of the favorable features about that esophagus and stomach cancer so easily accessible is we have a very low threshold to repeat endoscopies to get more tissue to make sure that we have tested for all the standard biomarkers and have enough tissue to stand for next generation sequencing.
I agree. I mean, we have basically the same experience.
Mhm.
I would say sometimes it's faster to almost repeat the biopsies than try to get outside tissue, especially when we're also looking and considering clinical trials that require
Absolutely.
sometimes, 15 slides of material for sponsors. Leslie, similar question to you. How often do you think that there's this balance of sort of need to start therapy, like, hey, let's just give Folfox and wait for the biomarkers versus waiting and getting everything? How often do you think, one of those or the other kind of happens?
I feel more often than not, we're saying, let's just get therapy started. As both of you know in your practice, these patients are often quite symptomatic when they come in. They're malnourished, not able to eat and drink. And we do know that that chemotherapy backbone can work fairly quickly to improve their oral intake, and adding on a targeted drug based off of biomarker results could happen after the second or third cycle. The caveat being, if you have an interesting clinical trial, wanting to try and wait as long as you possibly can, keep that patient as healthy and um, able to participate. But sometimes you just can't wait.
Yeah, I think, all of us that have done this kind of cancer for a little while, you kind of get that gut sense when you walk in the room if this is someone who can like wait or not wait. And that's, as you said, the nature of the disease, people coming very symptomatic, already a little bit behind the eight ball. Yeah, that's a judgment, that's the judgment part of all of our jobs. I want to hand this over to you, Leslie, to talk a little bit more about, you know, you alluded to this, which is it's a team sport, but maybe talk a little bit more about that. So I'll let you take over for the slides.
Okay, yeah, we'll start by talking a little bit about the multidisciplinary team. And as we've already alluded to, um, cancer care is complex and involves many healthcare professionals. This schema has the patient and its caregivers at the center, and then you have the medical oncologist who, in maybe a multi-D clinic, is in conversation with a surgeon, a radiologist on how are we going to manage this care. But then also into that goes pharmacists. How are we going to get this patient through therapy in terms of nutrition, social work, an oncology nurse? And so there's a lot of people working together to try and make this as successful as possible for the patient as well as the families that are taking care of the patient. Often you can run into kind of like the old adage, too many cooks in the kitchen. So when you have so many people working together, all with the best interests and their own experience and expertise, sometimes you can have communication and coordination challenges. And how do you make sure that everyone is communicating together if you can't get in on like a meeting face to face with, you know, the medical chart, all those types of things to make sure that the coordination of care piece is happening. I think the one thing I just wanted to point out that wasn't on here that I think about in terms of multidisciplinary teams, I think can look two different ways. I talked a little bit about how we have our specialty clinic at Fred Hutch with gastric esophageal cancer is kind of a way how patients come through. Often those patients are going to be your locally advanced or early stage that are going to get that multi team approach with radiation and surgery. If you have someone coming in through that has metastatic disease, they may just come through as a new patient in general into the GI clinic, but they still have a multidisciplinary team that's often being seen by advanced practice providers who are helping kind of coordinate all the day in, day out care in terms of treatment, clearing them for their therapies, managing chemotherapy or treatment-related side effects, as well as side effects from their disease. But then we also have our schedulers, which carry a whole different name in every different organization you go to, but they are really like the bread and butter that help put together all these pieces for the team members to make sure that they're seeing all of these integral members of the team. So kind of looking at this multidisciplinary team, what we have seen is it improves guideline adherence, diagnostic accuracy, clinical trial identification, outcomes, and professional relationships. There are barriers to effective utilization. You can have it from the operational side, time constraints, inadequate case information, poor team dynamics, information technology issues. You have the patients that can have an integral role here, fear of treatment toxicity, personal care goals, social drivers of health, as well as our healthcare professionals. And I think kind of alluding back to the turnaround time for biomarker results coming in is, are we having new or overlooked clinical findings that weren't discussed? Maybe some results came into the media file and it just never was, brought up. Or underestimating treatment feasibility. Like you said, you kind of get this gut feeling when you see patients and can decide, are they going to be okay? Are they not? And it's always evolving. And then I think just specifically, we wanted to take a minute to look at the pathologist because the CME program is really focused on biomarkers in these upper GI malignancies, looking at the role of the pathologist in these multidisciplinary teams. So the pathologist, is doing the initial biomarker testing and the interpretation. They may be asked to retest during therapy prior to switching therapies to determine the development of resistance or new biomarkers that may have come up. And then they also play a role in determining clinical trial eligibility. There are ways to try and improve pathologist participation, and part of that is to streamline and standardize biomarker testing process. So we kind of alluded to ordering and reporting already. How do we improve tissue acquisition, handling, and management to reduce turnaround time, and then strengthen their presence on the multidisciplinary team?
Yeah, I think we have pathology in our multi-D tumor board. I can't say they're there every single meeting. Sometimes it's hard with just timing and everybody's work schedule, but it is always helpful to get in front of the pathologists and hear from their side as well. Maybe I'll ask you, Sam, when patients are coming in, obviously we know multi-D tumor boards at initial treatment planning are important for all the reasons Leslie said. But when you have someone who is getting their response assessment, maybe in the perioperative space, maybe in the metastatic setting, like, do you bring everyone back for discussion? Only people where there's maybe some clinical debate? How do you guys do sort of repeat tumor board discussions?
Yeah, I would say it's not everybody, but it is certainly the cases where, perhaps things are a little bit more borderline, like perhaps a more advanced stage, but because of all this biomarker directed therapy and people are having, patients are having deeper and more prolonged responses, there's potential role for salvage therapy, salvage local therapies in certain situations. Or if someone who has just locally advanced disease becomes a bit more difficult, some of the regimens we'll talk about are a bit intensive and maybe they become a not, surgery becomes prohibitively risky or, things change upon progression. So we certainly bring some patients back, but not all cases, I think.
Yeah, yeah, same here.
Yeah.
And Leslie, sort of twist on that question, let's say someone is getting a biomarker-directed therapy and then it works for 10 months and then they start progressing. How often are you guys discussing sort of repeat biopsies and repeat testing? Is this a common topic?
I think it's a common question. I feel like the recommendation is often to retest, right, to see if because they've developed resistance, have they lost maybe some expression of HER2 or have they gained a new marker that we may be able to target? I will say in practice, I'm not seeing it as often that we do go and rebiopsy. Um, Whether or not that's just clinical performance, maybe they're declining and we start therapy. But I feel like there's still some discordance there in terms of how often we're doing it.
Yeah, I agree. We don't have a super standardized procedure that, every person says, hey, this X, Y, and Z happened, therefore you rebiopsy, but definitely a common discussion. And especially as Sam mentioned, trial eligibility. Sometimes you have to be HER2 positive for a late line trial. You have to confirm it after trastuzumab or whatever drug exposure. And so I think probably we're all going to need to become more familiar with this because it's going to be part of the future. Whether some of that can be accomplished by cell-free DNA for some biomarkers, I think, is possible for some, but unfortunately, many of ours are protein tests. So really can't do it that way. I want to make sure we have enough time to talk about all the data that actually underlies everything we've been talking about. Like, why do we have biomarker testing in the first place? And that's something Sam is going to walk us through. So Sam, I'm going to hand it over to you to talk about these current therapies.
Yeah, that sounds great. So let's frame some of the data that we're going to talk about, and just going through a case, starting here. 55-year-old gentleman, has a family, no history of cancer, no history of smoking, initially presented with some abdominal pain, maybe was losing weight intentionally at first, but then became a little bit unintentional, owing primarily to early satiety. So gets imaging done, which shows a gastric mass, some regional adenopathy, gets an endoscopy, biopsy confirms gastric adenocarcinoma. And so, he tells you he wants to be aggressive. And so going to the question here is, at what stage in this patient's treatment journey would you consider sending a tumor biopsy for biomarker testing? And I'll scroll here: prior to second line therapy, prior to first line therapy, prior to adjuvant, prior to neoadjuvant, or unsure. And we'll give a few seconds here just so everyone can think about it. See the responses coming in. All right, we seem to have plateaued. So let's see. So a plurality of people saying before first line metastatic disease, and kind of 10, 15, 20%. All right, well, let's go through it. So let's talk about some of the drugs here. You'll see these are the non-chemotherapy drugs that are driven based on biomarkers. So at the top, you have the top several. You have the immunotherapies. Durvalumab is a PD-L1 inhibitor. I'll skip ipilimumab for a moment. Nivolumab, pembrolizumab, tislelizumab are all PD-1 inhibitors, which are approved in advanced gastroesophageal adenocarcinoma. Ipilimumab is a CTLA-4 inhibitor, and although we won't talk about it today, is approved in esophageal squamous cell carcinoma in combination with PD-1 with nivolumab. And then you see on the bottom there, trastuzumab and trastuzumab deruxtecan are HER2 targeted agents, which we'll talk about in a little bit, and zolbetuximab, the new kid on the block, so to speak, Claudin targeting naked monoclonal antibody. And so the NCCN guideline does recommend biomarker testing in all clinical settings, including in patients with locally advanced disease, specifically testing for mismatch repair proteins to identify mismatch repair deficiency, which imputes microsatellite instability high tumors, which are very sensitive to checkpoint inhibition and immunotherapy. So we'll talk about that a little bit in just a little bit. And then, of course, HER2 and Claudin testing are approved for advanced and first line and second line metastatic disease. So we talked about this a little bit, but primarily for gastroesophageal junction and gastric adenocarcinoma, which we'll talk about kind of together because they do exist on a spectrum. These four immunohistochemistry tests are standard of care: mismatch repair proteins, PD-L1, HER2, and Claudin 18.2. And then, of course, next generation sequencing can identify some other alterations or copy number alterations, or including ERBB2 amplifications or other biomarkers that can help us understand how to best treat these patients. But I think first it's important to start. Let's go back to the case. This patient was stage 3 locally advanced gastric cancer, and these are the real 3 trials that will guide our decision making for patients with this disease. And I want to start with Matterhorn, which was just presented as an ASCO plenary and published just a few weeks ago in the New England Journal of Medicine. And you see the schema there on the top. So these are patients with locally advanced stage 2 or stage 4A in patients with T4 tumors. And the standard of care arm on the bottom is perioperative FLOT, which for those who are not familiar is 4 cycles of triplet chemotherapy, followed by surgery, followed by 4 cycles of adjuvant chemotherapy, which was established as the standard of care after the ASCO plenary the year before, in 2024, with the ESOPEC trial. And so Matterhorn asked the question, if we add durvalumab, a PD-L1 inhibitor that you saw on the previous slide, in combination with FLOT, will that help cure more people than chemotherapy alone? And so durvalumab with FLOT, and then also a period of durvalumab maintenance at the end. And you see here the event-free survival curves, almost a 8-9% improvement in 2-year event-free survival. So an early and then sustained separation of the curves. And even as you go out further towards 3 years, you see the FLOT arm appears that to level off at about 50%, whereas the durvalumab with FLOT, or I should be saying the DFLOT arm there, seems to level off about 10 to 15% higher. So certainly do seem to be curing more patients. This was very clinically meaningful and statistically significant. And based on this, is the new standard of care for patients with locally advanced disease. And as you can see in the overall survival curves, separate slightly later, as would be expected, but certainly still sustained, 4-6% difference at 2 years there. And although the p-value is 0.025 and the preliminary cutoff for statistical significance was 0.001, which it did not meet at the interim analysis, I will just say that the final p-value for statistical significance is 0.049. But so this right now has changed the standard of care. So you can see that patients are eligible for immunotherapy upfront. But as we think about the biomarkers, one of the ones that we talked about that is perhaps the most predictive of response to particular treatments is microsatellite instability. And so although it only represents about 5 to 10% of patients with gastroesophageal adenocarcinoma, and of course, it is a favorable prognostic biomarker as well, so it's enriched for patients with earlier stage disease. The NeoNapica trial was a phase 2 study that used this knowledge and said, what if we treat these patients with upfront double checkpoint blockade? So the PD-1 inhibitor nivolumab and the CTLA-4 inhibitor ipilimumab neoadjuvantly for 3 months, followed by surgery, and then followed by completing a year out of PD-1 inhibition. And the pathologic complete response rate in this phase 2 trial, which I believe was about 30 patients, was roughly 60%, which compared to chemotherapy alone, the perioperative FLOT has a pathologic complete response rate of about 10 to 15%, depending on the study. So really a remarkable improvement compared to the historical controls. And although the follow-up is relatively short, only about a year or two, there was only 1 event in the event-free and overall survival. So really, these patients with microsatellite instability high tumors are exquisitely sensitive. Their tumors are exquisitely sensitive to checkpoint blockade. And the Infinity trial was very similar initially, dual PD-1 CTLA-4 inhibition neoadjuvantly with durvalumab and tremelimumab, although there was no maintenance PD-1 at the end. You'll see the schema gets a little bit more complex up here on the top with cohort number 2, which allows for patients who have a clinical complete response, meaning no evidence of disease on scans, imaging, or endoscopy, to forego the morbid surgeries of gastrectomies or esophagectomies and be followed with non-operative management, followed very closely. And very similar outcome in terms of pathologic complete response rates of 60%, major path response rates of 80%, and also really outstanding survival that was seen with this cohort, which was just recently published in Annals of Oncology. And so, I think this is a really important point for discussion here, because we have these 2 phase 2 studies that are treating without chemotherapy for MSI high tumors, but now we have the Matterhorn paradigm. And so I'm curious, Sam, what you do in your practice, because now the checkpoint inhibition is available, or let's say theoretically it's available once, Matterhorn goes through NCCN or FDA, and there's no hoops we have to jump through. Single versus double. What do you think?
Yeah, very fair question. I think the message is, we need to test for MSI, and then if they're high, they need to have immunotherapy. Um, Optimal approach, I think, is not known. I'm encouraged by, I think single agent Pembro or Nivo is probably less preferred. We don't have as much data for that. If someone has a big bulky tumor and a lot of lymph nodes, I'm generally reaching for chemo plus immunotherapy. For someone who maybe has less disease, I feel quite comfortable with Ipi-Nivo as an option. So we've done both many times. I think we're probably never going to have real head-to-head data. They both work, and I think clinical judgment. Someone's got a huge tumor. There's always a chance that there's going to be some heterogeneous MMR expression in there, and maybe chemo gives you a little bit more of a backstop. So that's my tendency. We also have a bunch of questions that are relevant, so people are writing in. Thank you. I think this is actually probably a pretty good pause to handle some of these questions, which is one, I'll give this one to you, Leslie, which someone asked whether speech pathology professionals are ever included in the team, because a lot of our patients, especially those with more proximal tumors, have aspiration, etc.
Yeah, I would say that they're not like default on the list. We have incorporated all nutrition into upper GI at our institution. But we do use speech pathologists, especially when you have someone who is having dysphagia, you've done an EGD, it's fine. Maybe you do a swallow study to evaluate how to help manage those symptoms. And so we do use speech pathology.
Yeah, I agree. Sometimes tumors high up, knock out a laryngeal nerve if it's, a big node next to a esophageal cancer or a squame invading or something. I agree. I wish we could have more and more people on the team always, but sometimes that's just a staffing ratio problem at all institutions.
I always
Sam,
think I was just gonna say it's helpful too. I don't know after our gastrectomies or even after our esophagectomies, patients have, not so much after our esophagectomies, but may have a tube placed and are using
Mhm.
tube feeds as they're going through adjuvant therapy. And for patients who have been slow for oral intake, I always think getting speech pathology involved to make sure that they are developing those good swallowing skills again
Yeah,
after not utilizing them for some time. That's when
totally.
we use them a lot too.
Yeah, very, very good point. Sam, I'm going to bring this to you. A bunch of the questions are about biomarker testing, and we'll save a couple for the metastatic setting discussion. But, you mentioned testing in the non-metastatic patients. And so if you have limited tissue, how do you prioritize? Is sort of there an order of importance? And let's take a stage 3 patient, for example, now.
Yeah, good question. To me, the priority is microsatellite instability, mismatch repair, proficiency or deficiency, because that's really going to guide, even though that represents perhaps the smallest slice of the pie, like we said, only 5 to 10%, and perhaps slightly higher than that, or HER2 or Claudin or PD-L1 positive, but that's really what's going to drive your decision and have the most impactful outcome. So for me, it's microsatellite instability.
Yeah, I agree. What about you guys, Leslie, in the sort of non-metastatic setting, if you have to pick one?
I think we're still defaulting to PDL1 and HER2.
Yeah. Yeah, I think it's different patterns all around. I agree with our institution's a little more closer to Sam. We tend to do MSI as the priority, and then HER2 and PDL1 and Claudin, and especially depending on the trial portfolio, which comes and goes. Um,
Mhm.
And then we'll talk about sort of the metastatic setting in a minute, because some of these are good questions. And Sam, maybe I'll give you this one, which is probably something we're all gonna have to deal with a little bit more, which is um, now that we're gonna have perioperative immunotherapy with Matterhorn, we still are not curing enough patients, so many of these patients will recur, and they will have had a total of roughly a year of immunotherapy. Is there any reason to hold off in the neoadjuvant adjuvant setting in favor of the metastatic setting?
My answer would be no, because number one, you can see that the curves continue to separate, and so if you're holding off, then there look to be about 10 to 15% of patients who you are not curing that you otherwise could be curing. Now, of course, there's still, 30 to 35, 40% in there who are getting immunotherapy and now not being cured. And even so, there is still the separation of the overall survival curves. But as we get into some of the biomarkers, we see that sometimes you do have to make a choice between a PD-1 inhibitor and perhaps targeting a Claudin with zolbetuximab, because they're not yet approved together. So there is still rationale, I think, for giving immunotherapy upfront.
Yeah, I completely agree. One, improve the chance of cure, hopefully. And two, if you look as well, not a lot of people recur within 1 year. And so if you think clinically, you gave the person their last dose of durvalumab and then they recurred a year later, would you offer them immunotherapy? My answer is generally yes, only because in the metastatic setting, we have all of this data. I'll fully admit that those metastatic trials did not include patients who, for the most part, ever had prior immunotherapy. So it's a little bit of a gray zone. But I think clinically, we all use some kind of interval from adjuvant to the metastatic setting to decide whether we were going to, re-challenge them with immunotherapy. Same thing happened after Checkmate 577. So maybe it's a good time. I'll ask you, Sam, and then I'll ask you, Leslie. In multi-D discussions, when this kind of topic comes up, do you guys have like a magic number, 6 months, a year, more?
I think for immunotherapy, it's a bit longer than it is for chemo. If they got FLOT, how quickly you're going to go back to FOLFOX was maybe 6 months. But with immunotherapy, I agree. My cutoff is about a year. And I think my colleagues tend to be around that area, some a little shorter, some a little longer.
Yeah. And you, Leslie?
Yeah, I would say about the same for chemotherapy, about 6 months. Immunotherapy, a little bit longer.
Yeah, I think very much it's a place where we don't have tons of data, but that seems to be the predominant pattern, I would say, in my experience and also in our colleagues. So I want to make sure we get to all of the topics, and we'll definitely have a few more questions which are good, including some very practical and some very biologic. But Sam, I'm going to let you take over with this unresectable case, bringing us into the metastatic setting, and then we'll come back to more discussion.
Yeah, perfect. So in this case, we have a 65-year-old woman, coming in with progressive dysphagia in the background and context of a long history of heartburn. She gets an endoscopy, which shows a partially obstructing tumor at her gastroesophageal junction. She gets a CAT scan, shows very large tumor regional disease. Let's say our surgeons say it's unresectable, or even perhaps there's a distant metastatic lesion. So the tumor's biopsied and HER2 negative, PD-L1 CPS of 4, Claudin negative, and mismatch repair proficient. And I'll just even be a little bit more specific. Let's say HER2, because of course IHC on a scale of 0 to 3, let's say it's 0. And let's say Claudin 5%. So which of the following approaches is likely to provide the greatest clinical benefit? Systemic therapy with FLOT, systemic chemotherapy with an immune checkpoint inhibitor, pembrolizumab with trastuzumab and chemotherapy, nivolumab with ipilimumab, or not sure. Give it a few moments to see responses coming in. All right, we seem to have plateaued at around the same point. Great, so majority saying chemo and immunotherapy, and then a smattering of a couple others. So great, let's go through it. So I think the big paradigm here is that, right, and the takeaway is that this is, you can't know without your biomarkers. Without HER2, Claudin, PD-L1 mismatch repair, you're not sure. But because the patient is HER2 negative, that's, we'll see 3 practice-changing trials looking at chemotherapy with the addition of PD-1 inhibitors that you see listed there. HER2 positive, so in the frontline setting, untreated metastatic disease, KEYNOTE-811, trastuzumab with chemo, with or without pembrolizumab, and then in the second line setting, trastuzumab deruxtecan, the antibody drug conjugate, versus ramucirumab with chemotherapy. And then lastly, we'll talk about Claudin, the GLOW and Spotlight trials, which looked at the addition of zolbetuximab. So, starting here with Checkmate 649, which was the first positive phase 3 study in the first-line metastatic setting in over a decade, was a 3-arm study, but really the focus is that chemotherapy was the control arm. Just as a comment, the middle arm, ipi-nivo, was negative and was closed early. But then the arm that we'll talk about is the addition of PD-1 inhibitor nivolumab with chemotherapy, which improved overall survival in the entire intention to treat cohort. But the outcomes were enriched for patients who were PD-L1 positive, who had PD-L1 positive and PD-L1 high tumors. And so you see PD-L1 positive CPS, just as a quick sidebar for those not familiar, in gastric and esophageal cancer, we use combined positive score, which takes into account PD-L1 expression, not just of the tumor, but the surrounding lymphocytes, distinct from lung, which uses TPS. So positive being CPS of 1, high in this trial being CPS of 5. You see the overall survival numerically slightly larger based on the PD-L1 score, but certainly a significant improvement in overall progression-free survival in the investigational nivolumab arm, and also an improvement in response rates. And Keynote 859, very similar design. Won't go into all the very minor distinctions, but pembrolizumab instead of nivolumab, given once every 3 weeks, so slightly different. But you see here again, 1 year and 2 year overall survival, and again the benefit is enriched in patients with PD-L1 positive tumors and PD-L1 high tumors. In this case, PD-L1 high cutoff was a CPS of 10, slightly bigger gap, greater improvement in median overall survival and better hazard ratio. This is the progression-free survival. I won't belabor the point too much here so that we have some time to get through everything in the questions. And lastly, rationale 305. With tislelizumab, the main distinction here is that it used TAP, tumor area positivity, which is, hopefully there are no pathologists who will kill me for this distinction, but essentially eyeballing it instead of counting, individual cells, but still the same idea. And so based on these 3 trials, one which reinforced the other, PD-1 plus chemotherapy is standard for patients with HER2 negative gastric and esophageal cancer. Which now brings us very nicely into, well, what if let's take the same case, 60-year-old woman, gastroesophageal, distal esophagus, proximal gastric tumor that is HER2 IHC of 3+, right? So that's considered HER2 positive, 3+, or 2+ with a FISH confirming amplification. These patients, the standard of care was trastuzumab with chemotherapy, trastuzumab being the HER2 directed monoclonal antibody. And the investigational arm had the addition of PD-1 inhibitor pembrolizumab. And you can see initially improvement in progression-free survival, and then later published in New England Journal, the overall survival, and improvement in median overall survival, 20 to about 16 months, hazard ratio of 0.7. And so that is now considered standard of care, PD-1 pembrolizumab with trastuzumab and chemotherapy for patients with HER2 positive advanced disease. So locally advanced, unresectable, or metastatic. But let's say, unfortunately, a majority of these patients, even though they do better than they have previously done, still do progress. And as we talked about, there's real importance to rebiopsying because one of the mechanisms of resistance to trastuzumab is loss of HER2 expression. So certainly re-getting a biopsy to determine whether or not they retain HER2 positivity is critical. Destiny Gastric 04 was a randomized phase 3 study that was also just presented at ASCO and published in New England Journal that demonstrated that trastuzumab deruxtecan improved overall survival compared to the previous standard, which was ramucirumab and paclitaxel chemotherapy. So trastuzumab deruxtecan is an antibody drug conjugate, and one of the important distinctions with this compared to some of the other antibody drug conjugates that folks may be familiar with from the breast cancer world is that it has a higher drug to antibody ratio and a cleavable linker so that it really, once it gets in the cell, is able to have a remarkable bystander effect because one of the mechanisms of resistance in this disease is heterogeneity. So nearby cells may be HER2 negative or still effectively treated with trastuzumab deruxtecan. And here you see the progression-free survival curves. So this is second line, so still, of course, we have a lot of room to improve, but certainly a new standard for patients with HER2 positive disease. Shifting lastly here, and then we'll be able to get to some of the questions and some more discussion, is claudin. And so claudin is a tight junction protein that's expressed on normal stomach cells, but through the process of carcinogenesis becomes expressed on the surface of stomach cancer. And I just highlight this distinction, distinct from HER2, which is really driving the process. And so zolbetuximab is a monoclonal antibody targeting claudin, and both the Spotlight and GLOW studies evaluated zolbetuximab with a fluoropyrimidine and platinum doublet, FOLFOX or CAPOX. I think we all have pretty clear preferences on what on the doublet we might prefer, but showed an improvement in progression-free and overall survival. Now, claudin positivity in these studies was based on a claudin expression of 75% or higher. And so the patient that we saw earlier, claudin of only 5% or 10%, would be considered negative. So it has to be 75% or higher to qualify for getting zolbetuximab. And of note, there is some overlap between patients who are PD-L1 positive and claudin positive. And that's, I'm sure, one of the things that comes up in the questions anytime we have these sort of discussions. And we see here the overall survival curves, both GLOW and Spotlight, slightly different patient populations. So you see the medians are slightly different, but the hazard ratio is very similar in both groups. So just to summarize, because I know that was a pretty quick tour through just the last few years of all the practice-changing studies. So immunotherapy is now standard for patients with HER2 negative disease, the addition of PD-1 inhibitors with chemotherapy. For patients with HER2 positive untreated disease, it's trastuzumab with pembrolizumab, and chemo was superior to chemo alone. And then upon progression, trastuzumab deruxtecan is the standard. And of course, now claudin. So this really just drives home the importance that beyond chemo, you need these biomarkers to be able to help guide what the treatment decision is and what works best for our patients. So
yes. I think that the questions are getting to the two extreme scenarios that you hinted at. So maybe I'll start with you, Sam, for this one, and then I'll come to Leslie. So, it's a decreasing proportion of patients, but there are still people who have none of these biomarkers. So what do you do? I mean, do you give triplet chemotherapy like we saw with this GASTFOX trial, or do you give FOLFOX? How do you handle the people who are completely negative for everything?
Yeah, it is. I agree. It's a rare scenario, and will also acknowledge that I'm quite spoiled that we often have a clinical trial trying to fit this, our triple negative version. I rarely reach for triplet, usually because these patients, even if they have very bulky disease, tend to be pretty sensitive to chemotherapy. The ones who are resistant, the sensitivity tends to be fairly transient. But I think with triplet, you're just running through, you're heading on pretty heavy toxicity, and distinct from locally advanced, curative disease, this is a marathon, not a sprint. And so usually get enough benefit, symptomatically with doublet.
Yeah, I think that's our go-to. Leslie, is that your experience? People who are negative, you're going to doublets.
Yeah, usually starting with FOLFOX. But I think in this patient population, we'd really like emphasize sending off for next generation sequencing to help kind of set us up, hopefully, to maybe identify something that's being studied in a clinical trial in second or third line, just to try and see if they maybe have some kind of marker, maybe not one of the more prevalent ones, but something that could be driving their cancer.
Yeah, certainly an unmet need in our world of trying to find what does work for these patients. I think this is an active area of investigation, whether that's a PD-1 plus VEGF kind of combination thinking or totally novel targets. A lot of times in my experience, these are like the diffuse type gastric patients who are more likely to have none of this, or sometimes they just don't have enough tissue to feel confident that you have all the testing. Let's go to the other end of the spectrum, and I'll come back to you, Sam, for this one. So, what about the patient who has multiple biomarkers? And in this case, let's say, because it's another question in there about PD-L1 and Claudin positive.
Yeah. My preference tends to be for PD-1 inhibitor rather than for zolbetuximab. And I think provided they're PD-L1 high and Claudin high, and I think the rationale comes down to a few things. Number one, the side effect profile with PD-1 inhibitors tends to be more favorable. Zolbetuximab, you have these long infusion times. It's really harsh nausea and, issues with gastritis. And so PD-1 tends to be better tolerated. Number two is that there's an improvement in response rates. So there's deeper tumor regression, which for me, more than a surrogate for survival, is really a surrogate for symptomatic improvement in quality of life. And in the GLOW and Spotlight trial, zolbetuximab, although it improved progression-free and overall survival, it didn't improve overall response rates. And I think lastly is there's a tail on the PD-1 curves, Checkmate 649, Keynote 859 with PD-1 inhibitors. So immunotherapy is meaningfully improving the 3, 4, 5-year overall survival rates that obviously Spotlight and GLOW are a bit early, or a bit recent, so we don't have that yet. But I think those three taken together, my preference is for a PD-1 inhibitor. I'm curious what you both use in a similar situation.
Yeah, I think it's tempting to want to give everything together because we now have a fair amount of phase 2 data for the triplet or quadruplet, however you want to think about it. And if I had to guess, I think that if you ask me the same question 3 to 5 years from now, the answer will be FOLFOX Zolbe plus Pembro, or FOLFOX Claudin plus PD-1, just like it's going to be maybe FOLFOX plus FGFR2 plus PD-1. I think leveraging both of the advantages of target and immune therapies, and maybe even some cooperativity between the two, is probably a big part of the future. You mentioned nausea and vomiting, so I'm going to come to you, Leslie. Obviously, this is a newer drug. A lot of people don't have tons of experience with it yet, but any tips and tricks about the nausea and vomiting?
Yeah, and I think it kind of touches the question of like, how does this data translate into real world practice? Because it is very challenging to give zolbetuximab in the clinic because of the infusion related reactions. It's a long infusion, and plus then you have to add FOLFOX onto it. And we know that nausea and vomiting is one of the most feared side effects for patients. And so how do we, one, get them through the therapy and keep them on therapy? The biggest recommendations are to use a high emetic potential or antiemetic regimen. So, at least a triplet regimen for prevention with your NK1 inhibitor, your 5-HT3 plus Dex. And then, supportive medications throughout the infusion. And that support could look different ways. You're giving either additional antiemetics you haven't given, maybe you're stopping the infusion until symptoms resolve, and then restarting at a slower rate, and then slowly titrating up if they're tolerating. And then always thinking about how are you escalating any interventions going into subsequent infusions. There are a lot of recommendations on just the infusion rate itself, starting slow and titrating. The key point with zolbetuximab is the nausea and vomiting incidence does go down with subsequent infusions. So really trying to get through those first couple, and then hopefully the patient doesn't have as much nausea vomiting, but then you've also kind of fine-tuned their regimen that's going to work best for them.
Yeah, I think I'll tell you my own 2 cents because I know we're running towards the end of time, but the it is a long day, 4 hours plus about 4 hours for FOLFOX. So when patients are going to be there for a long day, one, I give all the pre-meds IV. I don't bother with PO Dex or PO Pepsid. I give IV Pepsid a fair amount as well. Also IV Benadryl or Ativan. I think patients are there for 8 hours, and sometimes being a little bit drowsy and sleeping through the nausea and vomiting is actually not the worst thing, because if you're asleep, you really don't have these symptoms. I learned this from our Japanese colleagues who have given many, many more patients this drug. And in my own experience, it's actually a relatively effective strategy. I mean, there are people who prefer not to have that experience, and the rates of nausea and vomiting are real. But I have found that a little bit heavier on the pre-meds, including antiemetics that may have a little bit of sedating properties, sometimes helps. So we're at the end of time. I'm going to take this back over and move us through the final slides, but we had a lot of conversation. Hopefully this was helpful for everybody. This is sort of a framework to think about this. Takeaways are, of course, we do have takeaways that should be smart or specific, measurable, achievable, relevant, and time limited. This was all a new one to me. But I think the punchlines are biomarkers should really be assessed at the earliest opportunity, like in the non-metastatic population. And again, if the patient recurs or if presents with de novo metastatic disease. I mean, this is on our guidelines. It's also very important in terms of guiding the therapy. You heard about the data, you heard about the clinical implementation. Multidisciplinary tumor boards, it's hard and it's a lot of work and it's extra time for everybody, but it actually makes a difference for patients. Like, we have real data that says, as Leslie said, it improves staging accuracy, we miss less things, we miss less biomarker testing, etc. There's some additional resources here at the website. Please visit the CEC website for additional information and other educational activities. There is this credit for you all, so thank you for coming and taking time out of your afternoon or evening. If you registered, you can get credit here. Just have to complete this post-test evaluation online and then just request the credit. There's 2 types of credit, which are listed here. And then finally, I would like to thank Sam and Leslie for joining and taking their time and being great discussants. And take care, and thanks for all the work that everybody's doing out there on behalf of all of our patients. Hopefully some of this will translate ultimately to better outcomes for all of our patients. So that's it for today, and hope to see you at a future program.